So good morning, everyone. Thank you for joining us here for parallel session 2.3 on how the geopolitics of commercial determinants of health can influence the impact of new technologies on health. My name is Saudamani. I work at the Health Intervention and Technology Assessment Program, or HITAP, in the Ministry of Public Health in Thailand. And it is my great pleasure to welcome you all to this session, together with an esteemed panel that has joined us today. Before we start, I'd like to acknowledge a few people that you won't be seeing on the stage. Professor Teo Yik Ying, who is the Dean of the School of Public Health at the National University of Singapore, who is leading the organization of this session, as well as the co-lead, Dr. Dennis Carroll, who also helped shape this session. Also, a big round of thanks to the HITAP team who are here to support today, as well as the PMAC Secretariat, the coordinator team, and the International Organizing Committee who have helped shape this program. So with that, with many of you here, I'd like to invite you to join us on menti.com so that we can get started with hearing from all of you. So either go to menti.com, www.menti.com, or just scan the QR code. If you need any help, just raise your hand. My colleagues will also come to help you. Okay, 6. Well, we definitely have more people than 6. It's thanks to the star power of our speakers that you have all come here on time, right after the break. Great, okay. Thank you all for joining, and you can continue to join using the code. It should show on top on Menti. So maybe the next slide, please. So while you might notice the temperatures in meeting rooms are quite cold and cool because of the air conditioning, but we would like you all to feel very energized and ready to participate. So we hope you are all feeling very excited and ready to engage, and that's already a great sign. So thank you for being so active and energetic. So now coming to the theme of our session today, and thank you for the PMAC team for putting the video before for a healthy and active meeting. Which industry, according to you, accounts for the largest share, is impacted by the commercial determinants of health? Mostly tobacco, food and beverage, fossil fuel, drugs. Interestingly, no alcohol. Alcohol, okay. All right. Okay, interesting. A lot on food and beverage, excluding alcohol and tobacco. I think interesting insights also from this morning at the plenary session on these different industries and their influence as well. So moving from that and coming to our title, we also want to push us to think what are some of the new technologies that you have encountered either in recent years or which you see coming up on the horizon that you think will be impacted by commercial determinants of health. AI, great. More AI. Okay. Generative, chatbot, monoclonal antibodies. Interesting. Vaccines. We truly are in the age of the post-pandemic period. Many AI and digital technology points. Interesting. So do hold on to your thoughts, and we'll come back to this perhaps when we have our panel discussion, as well as open the floor for questions. And as you can see, could you reflect a bit on what are some of the challenges that you think we encounter to tackle when tackling commercial determinants of health? Lack of public awareness being the most. So I think PMAC is doing a great job by showing us the videos before we start. Regulation, engagement, and okay, the World Trade Organization. So there are some of you who do think that could be a challenge or impediment, something for us to look into as we discuss further. Great. And perhaps So that we don't start off only on thinking of the negatives, what do you think are some of the opportunities that we have before us to tackle commercial determinants of health, particularly in the context of new technologies? Transparency, a greater push towards transparency, educating the public, and perhaps with novel technologies like digital technologies, globalization, youth, who are very savvy, one would imagine. Great. So education is quite front and center. Again, some food for thought as we go into this. And PMAC, that's great. I'm glad to have you all here. Wonderful. And perhaps, thank you so much for participating. With that, we'll keep the next question open for the remainder of our, during our session. So you can stay logged in and add your questions at will, and we'll look at them again in the panel discussion. So with that, perhaps we can switch now. And I'd like to take the opportunity to introduce our very distinguished panel today. We have three eminent speakers who will join us and share their perspectives on the topic at hand. First off, Dr. Soumya Swaminathan. She is the chairwoman of the MS Swaminathan Research Foundation in India and formerly the chief scientist at the World Health Organization. Please join me in welcoming her to the stage. I'd like to welcome all three guests to sit as we will be proceeding, if that's okay. I'll next invite Professor Gabriel Leung, who is the Executive Director of the Hong Kong Jockey Club, Charities and Communities. A lot of you, I think, who were at dinner last night would have seen him moderate the debate with great flair, and I'm sure he will keep us on our toes this morning as well. So thank you, Gabriel. Please join me in applauding. And finally, we'll have Dr. Precious Matsoso, who is the head of the regulatory forum at WITS Consortium in South Africa and was formerly the head of the Medical Regulatory Authority as well. She brings with her a great deal of experience and also at the global level. So please do welcome Dr. Precious Matsoso to the stage. Thank you so much for joining me. I'll briefly just share a few highlights for our discussion today. Next slide, please. Many of us are familiar with the invisible hand of the market that gives us the goods and services that we consume and produce. At the same time, they are shaped by very powerful forces that have directly or indirectly an impact on our health. Next, please. However, we have seen that many actors globally have come together to tackle the forces that we mentioned and try to improve health collectively, whether it's through the Doha Declaration to increase access to medicines globally, or in a seemingly bizarre situation where a government was taken to task for trying to protect the health of its population as well, and winning in that particular instance. And then finally, a slightly older example. Does anyone here know of this book by Rachel Carson? Just a raising hands. Okay, a few of you know. It's a book that's been credited with spawning the environmental movement, at least in the United States, and led to the establishment of the US EPA, or Environment Protection Agency. And as Professor Kishore reminded us in the keynote yesterday, our collective ship is moving towards an iceberg that is climate change. And this really helps remind us that we've come a long way from the 1960s when this book was first published. That said, we are presented with many new challenges, and as new and other technologies come to the market. One of the most expensive drugs was launched just last year. The price seems to keep going up, and this makes it challenging for patients and governments to increase access to care. And as we all learned during the COVID-19 pandemic, vaccines were a major path-breaking, game-changing technology, but alas, not in the hands of everyone and distributed equitably. So in today's session, we will try to unpack some of these issues and look at the geopolitical factors that shape these commercial determinants of health. We also will try to understand the challenges and opportunities that are at this nexus of health geopolitics and see what we can do to address them. With our very eminent panel here, we will hear from some real-world case studies and have, I'm sure, a stimulating discussion. So with that, I will now hand the floor to Dr. Soumya Swaminathan for her first intervention, which will be on COVID-19, as well as the experience at the global stage, to look at how to make it more accessible. Dr. Soumya, the floor is yours.
Thank you. Thank you, Saudamani. And good morning, everyone. Lovely to see all of you here this morning. So let me start perhaps by reflecting a little bit on our experience during the pandemic in terms of access to new health technologies. And if we go back to the beginning of 2020, when we all started understanding a little bit about this new disease, the virus, how it spreads, and so on. Of course, there was a lot of panic and anxiety, and we didn't have all the information at our hands, but we did know quite early on that people needed to protect themselves. And the first thing I think that we all saw around the world was the shortage of masks, personal protective equipment, and some very important essential things that we never used to think about, I think, till we reached the point where even we saw images of doctors and nurses wrapping themselves in trash bags and things like that to protect themselves, because they did not have access to the proper PPE, let alone, the general public having any access to it. And so starting with that, then moving on to things like oxygen, which again which is something that the world should have paid more attention to, in the sense that it was only after the pandemic that we saw that the lack of oxygen took so many lives. I mean, it's such an essential health product. And yet when you look into the availability of oxygen, we know many, many health centers around the world that even today don't have oxygen. And of course, more attempts were made during the pandemic, but it's such an important and essential health technology. We have many examples in our day-to-day life. We don't even have to think about COVID. You take a drug like insulin, which is again a life-saving product that was discovered just over 100 years ago now by Banting and Best, and they were very conscious of the fact that it was a life-saving technology. And so when they discovered it, they made a very explicit reference to the fact that this intellectual property, I think it was a $1 cost or something like that, for which they then gave it to the world, saying that this is a public good and it has to be used for the good. And yet today, when you look at the global situation, there are 3 big companies that actually control the market in terms of insulin. And what's called evergreening of patents, it keeps on happening. And so you find even in very high-income countries that not everyone has access to insulin, let alone people in low-income countries. So we can think of many such examples, including anti-cancer therapies, and Saudamani mentioned the drugs that are now being developed, the gene therapies, the very targeted treatments, which thanks to which people with cancer, people with inborn errors of metabolism and other genetic diseases are now able to live longer and lives with a much better quality of life. And yet, the majority of the world, these are not accessible. And even in the high-income countries, like I said, it's only a minority of people who can afford these $2, $3, $4 million tag treatments. So if we look at the whole value chain of the development and access to health technologies, we can focus on COVID as an example, but what I'm trying to say is that it's much more broadly applicable, and we heard this morning also about, the commercial determinants and how there's a complete failure of the market, so to speak, whether it's from the point of view of funders, whether it's the private sector that's actually developing these products, or whether it is governments that are regulating. So I think we have to think about what actions can be taken, and multilateral agencies, of course, like the WHO that makes standards, norms, regulations. But majority of the time, these are not binding, and the tobacco FCTC is one a very unique example of something that is binding. But the majority of WHO recommendations and guidelines, of course, are not binding, and so it's up to countries, how they implement them. The other thing I would say is a lack of intersectoral communication and action and discussions, which are absolutely essential if this particular problem has to be solved. It's not the health community alone that's going to be able to solve this, clearly. And the parts of government that deal with finance, with taxation, with regulation, with laws are very critically important. So if you look at R&D and how it's done and the models of R&D, of course we know that a lot of the innovation comes out of high-income countries today because of the investments that are made by governments. And you take the NIH, for example, spend over $40 billion on basic biomedical science through grants given mostly to academia. And these obviously result in a lot of innovation and generation of intellectual property, which is then taken up by the private sector and used to develop the products. And of course, you do need industry to do that. Academia is not in a position to develop products and sell it in the market. So you do need industry. They play a very critical role here. And without industry, without the companies that made all the COVID vaccines and things, we would not be in a position today where 14 billion doses of the vaccine were administered in those 2 years. So clearly they play an important role, but the gap here is that despite the taxpayer funding the R&D, the products of that R&D are then not accessible. And this is where we need reform. There is the Bayh-Dole Act in the US, which allows the government of the United States to have margin rights over products, and yet these are never used. It's similar to the TRIPS flexibilities that are there, of course, on paper, but they're hardly ever used. And when they are used, then those countries are usually met with a lot of pushback, a lot of negative influences and trade restrictions, and sort of almost like punishing people for using the TRIPS flexibilities. And so nobody's really very enthusiastic about using them. During COVID, we, as you remember, India and South Africa went to the World Trade Organization very early in the pandemic with a proposal for the lifting of intellectual property restrictions so that any new technologies developed for COVID, whether they are diagnostics, vaccines, or drugs, could be widely available so that companies around the world which had the which had the capacity could take that knowledge and actually start making those products. So if, for example, we had that, then we would have seen much earlier in 2020 and 2021, many more companies around the world potentially actually developing the rapid diagnostic tests as well as vaccines and the drugs as and when the drugs became available, though antivirals took a much longer time to develop. And I think there's, again, a market failure there. There's a gap globally in the development of antivirals. But what actually happened was that this resolution was never actually passed at the WTO. The can was kicked down the road, till in 2022, there was a very weak resolution that said, yes, this could happen, but only for vaccines, only during the pandemic, only so-and-so. There were so many restrictions that were placed. And by that time, it actually was irrelevant because by the end of 22, we did not need that type of what had happened had already happened. Now, what were the models of sharing of health technologies? The first one, of course, is that there's no sharing. So there were some big companies that had access to very excellent technology, like the mRNA, for example, that clearly said that they were not really interested to share that knowledge or technology transfer with anybody. Then there was a model of voluntary tech transfer, and this companies like AstraZeneca did that very well because, again, the IP belonged to the University of Oxford, so when it was transferred to AstraZeneca, there was that clause built in, and so they transferred that technology to at least 10 companies globally, maybe more, and companies like the Serum Institute of India were then able to make billions of doses of that vaccine. And so the AstraZeneca vaccine that was called Covishield in India, it had different names, different parts of the world, but that became one of the most widely used vaccines globally. So the voluntary tech transfer, of course, is something that's been used by companies for a long time, and they will continue to use it. But then the thing there is that they pick and choose. They decide who, when, where, and at what terms, and there's no transparency around the terms and conditions that the company actually uses for the tech transfer. The third model that was being promoted by the WHO with the Medicines Patent Pool and other partners was the multilateral tech transfer program, which is that the Medicines Patent Pool has used, for things like anti-HIV drugs, for example, in the past, where the technology is transferred under non-exclusive. So the first thing is it's a non-exclusive license. The second thing is the terms and conditions are very transparent. And thirdly, that it's available to people around the world based, of course, on certain conditions. And so that whole process actually is probably one of the best ways to improve access to health technologies, because you have a neutral party that has experience in handling intellectual property and that does it with public health goals. So I think the whole discourse here has to be, when we develop new health technologies which have a big public health impact, then how do we achieve that? And what's the best model to achieve that? Now, the WHO also set up the CTAP, or the COVID Technology Access Pool, that was meant actually for this, for companies or countries to put into that pool any health technology which they felt might be useful for the rest of the world. And so through that, then again with a partnership with the Medicines Patent Pool, we would have then gone ahead to transfer that technology. But eventually we had one or two technologies into that pool, and that too, they were not technologies that were greatly in demand. And so the CTAP mechanism, which actually the president of Costa Rica had proposed to the DG of WHO at that time, that was launched with a lot of hope, again, early in 2020, did not actually meet with any kind of success. Now, very recently, there was a case in the court in India, the Supreme Court of India, where two young women who had suffered from multi-drug resistant TB actually went to the court to fight against the evergreening of the patent by J&J for a drug called bedaquiline, which is a life-saving drug for people with multi-drug resistant TB. They won the case, and so the patent was due to expire in 2023, and J&J was trying to extend that further. So these two young people, both women, they were featured in the Time magazine's list of most prominent individuals last year in 2023, one Indian, one South African. They were able to fight that case and have it thrown out. And so, again, a life-saving drug that should be accessible to people around the world, but there was attempts being made to prevent that from happening. So perhaps I'll give one last example, which is the mRNA technology transfer program that I think I also spoke about yesterday, so some of you already know about it. But essentially, it was a response from us at the WHO at that time to what we saw happening around, which was companies refusing to share their knowledge. And in the case of vaccines, it's not just the patent that needs to be waived. So it's not just a question of the WTO, giving that waiver, though that would have helped. But that's not enough. What you need is tech transfer. You need the knowledge, the technology, and the entire process of making that vaccine to be shared. Now, since both Pfizer and Moderna were not willing to do that, we said, let's do it on our own. And we were met with a great deal of skepticism at that time. I remember conversations with people around the world saying, this is not going to work. This has never worked in the past. But we said, well, we have to try, because we can't just sit back and say, this is the way things are going to be. So we developed this network of what we call the mRNA hubs and spokes around the world. 16 countries now are involved in this. The hub is in South Africa, in Cape Town, in a company called Afrigen, and there are spokes around the world. What they're doing basically is that scientists are working together to share and develop mRNA technology further, because what we had during COVID was not exactly suitable for tropical countries. You had to store that vaccine in -70 and things like that. Today, there's a way of making heat-stable mRNA. There's a way of simplifying and reducing the cost. And so these companies are working not just on COVID, but on mRNA tech to be used to solve many of the challenges we face, whether it's infectious diseases or whether it is things like cancer. And so that type of approach where people are not holding on to IP and patents. I mean, one of the things of being involved in this program, one of the conditions is that whatever new IP you generate will be shared, but done in an equitable, transparent way through the medicines patent pool, but it will benefit people around the world. And so this program has got a lot of support. We'll have to wait and see over the years what it generates, but it's a very alternate way of thinking about the traditional model of R&D, where taxpayers actually fund research, but then it's controlled by big business and profits rather than for a public health purpose. So I think I'll stop there, Saudamani. Thank you.
Thank you so much, Dr. Soumya. That was a really inspiring note to finish on as well, to see that we've come a long way and there is one step in that direction with the medical patent pool, and would like to hear more about that when we have the panel. So any clarifying questions from the hall? If not, we'll move to our next eminent speaker, Professor Gabriel Leung. He will be speaking on the experience in the post-pandemic period, building on Dr. Soumya's intervention, and talk about what this looks like in China and whether free markets are the answer to this question. Professor Gabriel, the floor is yours.
Thanks very much, Saudamini. And again, very, very privileged to be asked to share a few thoughts with you. When we had the original planning Zoom that Saudamini very, very wisely and cleverly steered, we sort of brainstormed with fellow panelists and the Secretariat, all right, how are we going to pull this all together and make it coherent? And so obviously with Soumya's experience at the WHO as the chief scientist during much of the COVID outbreak, it made a lot of sense for her to talk about the global situation, how the WTO, how individual countries, and how interrelations between countries and geopolitics actually either converged or diverged with the commercial determinants of health, i.e. big pharma and the vaccine manufacturers, to protect or not the global population or different subpopulations in different countries. So I was given the task of saying something about the Chinese experience. So I thought, well, let me perhaps try to speak to the post-pandemic COVID experience rather than revisiting COVID pandemic itself. Everybody knows that China was one of the last countries, certainly the last large country, to have made the decision to transition out of the pandemic. And so the different waves Alpha, Beta, Delta didn't really hit China. It was a very, very robust regime of a combination of PHSMs, including the use of health tech, i.e. the WeChat app, to work together along with the software, the human software of neighborhood volunteering teams all over the country. And that was really what held everything together until Omicron. Now, in the post-COVID pandemic era, if I may have the first of my two slides. Thank you. This is essentially, as of about a month ago, when the couple of slides were put together, availability of boosters. All right. Now, first of all, before I even speak to this, if you just sort of orient yourself to what this fairly complicated and busy table shows is on the leftmost column, you will see the vaccine manufacturer, and they are all in China. Then the booster that they are producing. And just in lighter print underneath the names of the boosters, the kind of technological platform, the vaccine platform. So ranging from recombinant protein or protein subunit vaccines to mRNA, and ranging from IM injections to inhalation type vaccines. And that's the last one, the CanSino, the adeno vector vaccine. And then the third column gives you the strains that are included in the booster shot. Okay? And then the rightmost column gives you availability. So when did it become available? Now this is all for the winter wave of COVID. Even without knowing any biology or epidemiology or vaccinology, if you ask a child to look at this, I suspect the child might kind of spot that the column, the second from the right or the third from the left, i.e. the strains, they look quite different. They look quite different. Now, if you then know a little bit about influenza, seasonal influenza shots, and if you plot out the same thing, they would all look the same for the northern hemisphere and for the southern hemisphere, because those strain selection exercises take place as coordinated by the WHO every year. So now everybody's looking at the southern hemisphere winter vaccines, and then in a couple of months' time, the northern hemisphere winter vaccine strains for the end of this calendar year will be chosen, right? The whole point of this strain selection exercise coordinated by the WHO is that that column looks identical by hemisphere, regardless of which country you're in, regardless of which vaccine manufacturer you are. If you're producing vaccines for that particular season in that particular hemisphere, that's what you follow. But while COVID is definitely not flu, it doesn't have any resemblance to flu, and you shouldn't treat COVID like flu, even in the post-pandemic phase. But isn't it a little bit perhaps surprising that they look so different, that there's such heterogeneity? Because surely, now, and this is even more sort of perhaps surprising because they're all Chinese vaccine manufacturers essentially with the domestic market in mind. This is not for export. The one COVID vaccine that was for export, and a lot of countries actually represented here, said to me they really appreciated the Chinese inactivated vaccine produced by Sinovac, because they all received these vaccines very early on, and those were the only vaccines that were available, particularly in some LMICs. But just in case you haven't heard, Sinovac has stopped producing COVID vaccines. That was an announcement a month ago or 2 months ago. So you don't see Sinovac here, but you do see others, and this is all for domestic consumption largely. So you are looking at essentially the same country, but how come you are using different strains? Now, you could say China is a very large country, and therefore it also spans quite a bit of latitude, and therefore, well, maybe there is some difference, maybe, but maybe not. China is very well connected by all sorts of transport modes, very efficient ones, and Chinese New Year is coming up, which is the largest human migration on Earth that takes place on an annual basis. There's a 40-day period where essentially you mix up the entire national population, all right, because people go home, go back to their hometowns, go back to where the parents are, where the grandparents are. So surely it doesn't really make very much sense if you actually look at the strain selection here. So that's the first thing, without knowing anything about immunology or biology. Second thing is availability. Most of them, with the singular exception of the first one, only became available very recently. Available meaning approval. Very recently. This is weeks ago, 6 weeks ago. So even with the best distribution network, you need to have allowed some lead time in order to get it down into arms, okay? Because there is procurement strategy, so on and so forth. And generally, procurement agencies don't start pre-procurement processes until something is actually approved, right? So timing is the other issue. And generally, you would want to give a 2-week window between having it in your arm, or in the last case, breathing it in, and actually having it take full effect. Now, given that Spring Festival or Chinese New Year travel generally starts a couple of weeks before Chinese New Year Day itself, which is February 10th this year, essentially, you would need to be pushing a lot of shots into people's arms right now in this coming week, if it's actually going to work for when they actually travel and go and meet the parents and everybody else from all around the country. So that's the second interesting observation. There's no value judgment, but I'm merely pointing out some facts for your consideration. Now, the third thing requires a little bit of knowledge about a phenomenon which is quite interesting because it borrowed from the very first book of the Jewish or Christian Bible. It's called Original Antigenic Sin. This whole idea is about immune imprinting. This is not a new biological concept. What it is about, though, is that it basically says your immune system for a particular pathogen or particular bug is primed by the first experience it has with that particular bug. And therefore, in subsequent exposures to related varieties or strains or variants of that same bug, your immune system would preferentially produce antibodies that would react and anticipate meeting the same strain or the same variant as when you were originally exposed. And if the circulating strain or circulating variant is antigenically quite far away from that original strain or original variant, then you are not going to be as well protected, even though you have been boosted by something else. And that's quite a complicated concept or set of concepts, but it's been shown to hold for COVID as it does for flu, as well as many other viral pathogens. Now, if you think about that, then you will say, look, let's say that I was actually first exposed to this by a vaccine, okay? And that vaccine contained the original strain, the so-called Wuhan strain or variant, and let's say the beta variety, which is basically what a lot of people got in China, okay? So the first exposure to this bug was not natural infection. They got the shot first. So that shot would have then predisposed their system to kick in, and if you see it again, they would respond very well to the original variant and to beta, but not obviously to XBB or BN1, which is actually now circulating and prevalent. And let's say that the second time they saw it was actually Omicron, okay? Was actually Omicron, BA1, BA2, whatever. And that was the natural infection. That's the huge surge when China lifted those strict PHSMs. Now, the second time they saw it, they were somewhat protected from very serious illness because they got the original Wuhan variant vaccine, so it protected them at least via the T-cell system or the cell-mediated immunity system against the bad stuff, the ICU admissions and the deaths. And it somewhat started to shift that antibody or humoral immune system towards the XBB, towards the Omicron space, okay? Not XBB yet, but towards the Omicron antigenic space. But old habits die hard. That is why it's called original antigenic sin, immune imprinting. So it only started to shift it a little bit. So presumably, if you want to then now protect people against them mixing with each other and then getting infected with BN1 Omicron, okay, over Chinese New Year or Spring Festival, you would want to shift that even more towards the Omicron variety, okay? I.e. the latest and the most popular one is XBB, okay? So you would want to give them a vaccine that is XBB, and probably XBB only, because you want to shift it. You want to keep on pushing it. What you don't want to do is to boost the original Wuhan variant or beta or delta or BA2 or BA5, whatever it is, right? You don't want to remind them of the old stuff that's no longer circulating because it's already quite biased. Now, if you then compare it with these, then you say, well, why are you still giving people, for example, the second one, why are you still giving people the original strain? It's gone. Their first exposure was that. Their natural infection was Omicron, which started to shift them towards the right direction to protect them from BN1 now. But now you're reminding them again of the old one, which they are already predisposed to. Why do you want to do that? Now, here comes the crux of the commercial determinants of health. Each individual vaccine manufacturer has got their own formulation. Why? Because they think that that would give them a market edge. And if you don't completely or entirely understand the biology of this, and it's very difficult to repeat what I said in the last 15 minutes to the general public. But generally, and here, I am a primary care doc. When people come in for upper respiratory infection, the common cold, generally people judge who is a better doctor by how many pills and bottles of syrup they get. Generally, I'm deemed to be a very bad one because I generally don't give very much, right? So they'll pay more if they get more, right? Now, they might actually use that conventional wisdom and say, hey, if I'm going to have to pay for this thing, I might as well get a few more strains, more protection, wider, broader coverage. I mean, don't laugh. I mean, this is actually folk wisdom, right? Unless you understand the very complicated immunology and biology, which is still being debated. It's been debated for 40 years. Unless you really understand that, and unless there is regulation, which is the number 2 thing that you voted for in your Mentimeter, and standardization, this is what results. How is somebody actually going to decide which one they pick? Okay, so that's something that perhaps is worth just reflecting on. Now, if you then go to the next slide, different large health authorities in different parts of the country, and when they made the announcement to tell the populations what vaccines are primarily available, particularly through the social insurance system. And then the eligible groups, okay? The eligible groups is fine. They generally follow WHO SAGE and on the conservative side, all right? I sit on SAGE, so I know that they have followed it. But you will see that all over the country, basically only 2 vaccines, publicly, generally procured and given through the social insurance system. And then if we go back, remember those 2 vaccines, if we go back one slide, they happen to be the first one and also the second last one. And what do you see? They are the multi-strain ones. Probably not the most optimal, shall we say, if you believe immune imprinting in viral diseases. Okay? So there's a lot of these considerations, and you'll say, well, why do you see this kind of thing? And the last layer that I'm going to try to perhaps suggest is a lot of vaccine manufacturers all over the country, some of them are owned by regional governments, some are semi-state owned, and generally if you look at the procurement patterns, they tend to buy local, okay? So if a particular province A actually owns a particular vaccine manufacturer, then they would, by and large, not just for COVID, but for flu and other things, generally try and buy local from the same regional manufacturer, okay? So again, a determinant that is not entirely or wholly based on immunology or biology or the scientific base. So those are the very subtle things that if you really look very carefully, you would try and reflect and think about and then see how we may improve the system to better protect our populations. With that, I thank you and look forward to learning from you in the discussion.
Thank you, Professor Gabriel, for giving us that crash course in the immunology of COVID vaccines and strains. I think we've all also learned a lot. And you've now highlighted a point about under-regulation as well, which we will have our next speaker, eminent speaker, Dr. Precious, speak to. And again, not just for COVID vaccines, but also more broadly across the health spectrum. So over to you, Dr. Precious.
Good morning. Thank you. Well, I'll take this opportunity not to speak about COVID, but I think your discussion set a very good base for my inputs. Firstly, private sector activities can affect people's health positively or negatively, directly or indirectly. But this depends on public policy and how best we regulate. So good regulatory environments are those that are free from political pressure or commercial influence. And we've heard what commercial influence can do and what political pressure can also do. So the question is, how do we achieve alignment in policy, and what kind of decisive actions do we need? But also, how, with this technology, we can ensure that it can contribute to the well-being of people so that they can be better, or we can get good health outcomes. There are also other aspects, the prohibitive costs, how these can be dealt with so that people are not denied access, or where coverage can be unequal. How can we deal with these commercial determinants? So there are opportunities to deal with this, and I would like to deal with this framework, but I want to pose it in a form of questions first. The first one is how best we navigate the regulatory space in a complex technological environment. Because with new technologies, the complexity of regulation is a big challenge. The first one is we have predictive medicine, we have artificial intelligence, so the capacities to regulate, has a big problem, particularly in those countries with limited resources. But again, it's also how we deal with the intricacies of the interplay between state regulation, private orderings, public interest, and global challenges. So it's also about trade-offs. So how do we achieve those trade-offs? And what are trade-offs? So the geopolitical environment also has to do with the fact that some countries are producers. They could be producers of tobacco, and they would want to protect jobs at the expense of public health. Others may be producers of sugarcane and may protect employment and trade. So what are those trade-offs that we have to deal with? So I propose here a framework that should apply across all regulatory environments, whether you regulate tobacco, alcohol, sugar, beverages, and other areas. And these are regulatory approaches for consideration. The first is how you under-regulate, and we heard about under-regulation and what the potential risks are. Under-regulation subjects citizens to harm. But again, over-regulation is the other end of the spectrum. If you over-regulate, we don't know what the benefits are of strict and extensive regulation, and I repeat, extensive regulation. But again, is self-regulation an option? Self-regulation presents the risks of lax standards and poor industry regulatory commitments. What about co-regulation? Co-regulation leads to regulatory capture. So what is required? So there are a few regulatory approaches that may be considered. The first one is responsive regulation, and this is what works when there are capacity constraints. Governments do not have abundant resources. So what would be the best possible way of regulation? The other is essential regulation. What is pragmatic? And how to promote transparency as you regulate. The next is effective regulation, which is more context specific. It takes into account the environment and the policy environment in a particular area, and geopolitics. And lastly, command and control. Command and control may stifle innovation. It may erode trust. Not only trust from the commercial perspective, but public trust. I want to share the COVID experience, for instance, in South Africa. When COVID happened, there were regulations over and above the existing ones that were implemented. There was a total ban, and I repeat, total ban on tobacco and alcohol sales. So meaning you could not buy tobacco, you could not buy alcohol. So there was public outrage. And it was interesting because it was in public interest and to promote public health. But the public were outraged. So subsequent to that, we then had court action from the industries against government. And the outcome was that it was unconstitutional, it was an overreach, meaning it went beyond the requirements because we already had regulations on alcohol and tobacco. So how do you avoid that to bring about a balance? What kind of actionable strategies do we need? How do we deal with under-regulation? So we need to choose the best strategies and determine what we call the hierarchy of strategies in a form of enforcement pyramid. With regard to overregulation, to avoid overregulation, we need to conduct socio-economic impact analysis and assess regulatory performance from time to time. With respect to self-regulation, there must be purposive focus specifically on how best industry should comply to certain minimum standards and practice guidelines, meaning you can't just leave it to industry to self-regulate without any monitoring systems and reporting systems. And core regulations, this one goes hand in hand with good governance and reporting framework. With regard to responsive regulations, we must have activities that deal with two aspects, whether you want to be less stringent and regulate more activities, or you want to regulate few activities and be more stringent. So a question of choice in these two options will determine on your resources and capacity. With regard to essential regulation, again, here it's about principles of good regulatory practice. An effective regulation would be more a balance between intensity and scope, but it also is based on strategic anticipation of those who are going to be regulated, so that there are no shock waves, meaning you don't announce today that this is regulation, it comes tomorrow. And with no capacity on one hand, but others not being able to comply. The command and control punitive measures are always a source of being undermined by industry. Industry tend to undermine punitive, they cut corners, they find ways to avoid them. But again, where there's no trust and there's trust deficit, we have to ensure that we build the confidence of communities. So in South Africa, we've had multiple regulations, as I conclude, on tobacco, alcohol, but largely regulated by Treasury in a form of sin tax. But as to whether these resources should be redirected back for public health purposes so that we can use them for health promotion has been a debate, because Treasury always challenges any earmarked taxation and so on. They want a much more broad tax base. Even if they collect fiscus, they do not allow for that to be earmarked for particular issues. So like I said, the most important, as I conclude, in relation to what my previous panelists spoke about, of procurement and access, was about transparency and the disclosures when contracts were signed for COVID vaccines. You've seen court actions from South Africa where transparency and accountability were a key issue. And I saw when we had the mentees earlier, transparency came up. And as we deal with commercial determinants of health, transparency and accountability must be integrated into our regulatory framework. I thank you.
Thank you so much, Dr. Precious, for setting that stage and calling for a more agile, so to speak, regulatory environment and response, but one that is attuned to the capacity constraints that many countries, especially low and middle income countries, might find themselves in. So thank you for setting us up for that. I think for the next part, we'll start with a panel discussion, and so that I don't come across as too selfish to have all the panelists only responding to my questions, we'll then open it up to all of you. So please start preparing your questions. I also am aware that some of you have shared questions on Menti, which will show up as well. So maybe to get started, I'll start in the order of our speakers that presented. So Dr. Soumya, you spoke about the medicines patent pool. Seems too good to be true in some ways. Or would like to ask you whether that is the case, or what do you think is one of its strengths and what could be its potential pitfalls? You gave an example about COVID where countries such as South Africa and India tried to have a waiver for the patents for vaccines, did not succeed to the extent that we would have liked. And similarly, you said Costa Rica as well tried to have put forward a proposition. Where do you think this particular mechanism could succeed going forward? If you could reflect a bit.
Yes, thank you, Saudamini. And it's interesting that during the course of these IP waiver discussions at the WTO, Europe actually said, well, you should use compulsory licensing because that's already available through the TRIPS flexibility. So why are countries not using compulsory licensing? Whereas from past history, we know that those who have tried to use, including Thailand, compulsory licensing, have faced very adverse consequences. And in any case, as I said before, in the case of vaccines, it's not just the patent, it's really the transfer of know-how that's needed. So I think the medicines patent pool, has had successes, obviously, but in a limited area. It started with HIV drugs, and some TB drugs, and now they've expanded their scope to to some non-communicable diseases. And during the pandemic, obviously, they partnered with the WHO in the CTAP, the COVID Technology Access Program, and in the mRNA Tech Transfer Program. So they were set up actually with the goal of serving public health through making access to health technologies more widely available as I said, in a transparent manner with a certain sets of rules and regulations and compliance requirements. So I think that's the plus point, is that that was the mandate, and that's how they have functioned, and they've had success in that limited sphere. Of course, they don't have the capacity to take on every health technology that's needed today, and we've heard about many new health technologies that are being developed in one part of the world. There's a huge need in other parts of the world, but they're not currently available. And so we need, I think, the philosophy, the rationale for the medicines patent pool needs to be much more broadly applied. And I really think that international trade rules, which I think so far probably have not thought about health or public health when they discuss trade, international trade. If there were to be discussions, serious discussions at the WTO, for example, then it would be not just health technologies, but I think some of the things, the trade-offs, as Precious was referring to, that happen within the boundaries of a country. But a lot of times things are pushed internationally because of certain trade regulations that maybe the weaker countries are unable to really push back against and resist. And I think Mexico's example of trying to bring in very strict regulation on food labeling because of the huge burden of obesity that they face, this was actually challenged at the WTO, mainly by the big multinational companies that are promoting a lot of these unhealthy foods, with the support of their governments to challenge Mexico on saying that this was actually illegal to do this type of front of pack labeling, whereas exactly that's what is needed for their own public health epidemic of obesity that they have, and many of our countries are going through that transition now. So we need, I think, at the global level, much more discussion of the commercial determinants of health, and in addition to, so I think that's the theme here, is geopolitics. Can countries come together and say the health of people is important, and collectively we need to do something to promote health, not things that are adverse to health. So that would be an aspiration, I think, globally. But secondly, at the national level and perhaps at the regional level, to have regulations, as Precious was saying, that promote health, that are responsive to the needs of your own population. And of course, then you have to be able to bear up or confront the pressures that would be brought upon you. So that's the challenge, But I think national regulation and a global understanding and regulation, and of course WHO plays an important role in advocating for these kinds of, and I understand there is a framework convention on ultra-processed foods that's being discussed. So I think we need things like that also to set some standards for countries to be able to follow, on the lines of the Tobacco Convention, perhaps. Thanks.
Thank you so much, Dr. Soumya. We'll come back to many of the points that you've raised, I'm sure, over the course of the discussion. So maybe perhaps to Professor Gabriel, you spoke about the experience in China. Given the large size and influence that China has globally as well, could you perhaps reflect on what are the implications of these developments for countries around the world that China has relationships with?
I think that, look, this is, I gave a very brief case study of my country. Well, first of all, it is 1/5 of humanity. Secondly, it is very, very well connected with many, many parts of the world. In fact, this city is the most visited by Chinese tourists. Hence, you remember in 2020, in the very beginning, in January, this was the place that had the first case of COVID outside of mainland China, Tokyo being the second. So I think that we live, I mean, it's now become such a cliche. It was true already during the 97 bird flu outbreak centered around Hong Kong, certainly true in 2003 during SARS, and it is now such a cliche to say that the world is very interconnected. I mean, that's a statement of the obvious. But I do think that China is already very fortunate and privileged to already have self-sufficient capability to develop and produce vaccines, enough for its own people, and as the COVID experience showed, for many other countries around the world. This is not true for the majority of countries around the world. Hence, the South Africa hub, that particularly for mRNA technology, that Samia just alluded to in her opening remarks, and indeed several such hubs to make sure that we have good, perhaps not, we don't need 190 plus countries all to have the same capability, because that's unrealistic. But I think that we do need to have many more hubs of excellence that could quickly and reliably produce sufficient vaccines to ensure access. That access is not socially or economically patterned, which sadly, during COVID, it was still, despite the rhetoric, despite COVAX. Jesse Bump yesterday, I think, asked everybody to vote with their feet, or at least their gluteus maximus, the muscle that you need to stand to gauge your views of COVAX. But this is most unfortunate, and I suppose could have been a little bit foreseen. Dr. Suet was telling us that Thailand, being a public health and global health pioneer, and really, really sophisticated in their strategic approach, actually was remarkably not a COVAX signatory, and for good reason. Now, in hindsight, they had been very prescient. So, how do we make very sure that this doesn't happen again? How do we perhaps look at the Serum Institute of India, which is really, for much of the world, and particularly the LMICs of the world, the vaccine center and lifeline, quite literally, and how China, with Sinovac, really, again, adding much to that pipeline, using that inactivator platform. Oh, incidentally, you also notice that there had been a lot of, I think, misinterpretation of the inactivated vaccine platform. And our studies have shown that definitively that it would require one additional dose for a primary series, but it actually is just as protective as any of the other vaccine platforms, without many of the side effects. But even China itself, for domestic consumption, on that slide, there was not a single vaccine that is the inactivated platform. That's another interesting observation. But in fact, if you actually ask the immunologists and the clinicians, many of them will actually tell you, I wish I have access to an inactivated Omicron XBB booster or BN1 booster. Because as a booster, you probably don't want or even need to have that kind of potency as some of the other platforms, particularly the mRNA platform. So, those are, of course, commercial choices. Those had not been discussed or coordinated either at the supranational level by the WHO or even at the national level, clearly, because otherwise you would see uniformity in the variant selection. And that's something that I think, while diversity and inclusiveness and heterogeneity is generally good from an ecological or natural ecology sense, there are some areas where perhaps we might wish for more coordination. And it's, as Precious has pointed out, I think it's always a very, very fine line. When is it too much and overbearing, and when is it not enough? And the same answer usually doesn't hold for even the same bug, but in different periods, because it changes. So this dynamical nature of what may be optimal also needs to be very thoroughly considered and thought through. And that is, I suppose, what keeps us all interested in what we do and motivated in what we do, and quite frankly, employed. If it were that simple, many of us would be out of a job.
Thank you, Gabriel, for that very provocative thought. You also highlighted the importance of coordination at the national level, and also the importance of regional hubs, which Soumya also alluded to. And perhaps on that note, I'd like to ask Precious, Dr. Precious, if you could comment a bit on regulatory approaches that are perhaps at the regional level and can also help countries that may have differential capacities to coordinate a bit better and also be able to benefit jointly from resources.
Yes, thank you very much. I happen to be an advocate for harmonization. And we sort of started the harmonization agenda in Africa through sub-regional blocks. I mean, I led the SADC Harmonization Initiative, which involved 15 countries, and we also have the Eastern African Community Harmonization Initiative, and we have ECOWAS harmonization. But we also recognize that having these and there's IGAD, which is also a handful of countries. And we also have for the Francophone countries, which is EMOA. So there are different blocks within Africa. So over time, there was an understanding that you needed a much more integrated approach. And it's for that reason that we had the African Medicines Agency. But it's still new, and not much has been done as yet. But if I go back to those that already exist, so within SADC, there was a subset of countries that started doing actual evaluation of application for approval. It's called Zazibona. And Zazibona is an acronym for countries, Zambia, Zimbabwe, Botswana, and Namibia. So those were the original founders of the initiative, which in the SADC region. So what they do, they jointly assess applications and they approve them and share experiences and so on. But what I've seen, and I want to use the COVID experience, is that with the emergency use authorization and the listing, because some companies just apply directly to countries, they approve even those products that had not been granted emergency use listing by WHO. Like, for instance, your Sputnik and so on. Some countries approve them and use them. So our view is that these harmonization initiatives may be the basis on which these can be jointly assessed. In the event that they've not been considered by WHO, at least there'll be this shared knowledge and mutual recognitions of some sort, or where other information exists. They may also have regulatory reliance approaches, for instance, and use that as a basis of decision making. As you know, there are very limited models of conducting benefit risk analysis. There are probably well-established and regulatory agencies that have conducted these benefit risk analysis. And I think we've been looking at models on how in resource limited settings, how you conduct those. Because depending on your epidemiological profile, burden of disease. I mean, for instance, if you have a malaria vaccine, like we saw Cameroon is the first country to use the vaccine, if it was developed, say, in the US or in Europe, and you obviously would have conducted your clinical trials in regions where the malaria is endemic. But also you'd also want to understand how this would be used in real settings. And there are also ethnopopulation dynamics. If a study has been conducted in Africa and the vaccine has to be used in China, for instance, you may need some bridging studies. So there are a lot of considerations. And I think the harmonization initiatives are taking into account all those dimensions. Thank you.
Thank you so much, all three of you. We have a few questions on Menti, but I'd like to turn to the floor. If anyone has a question, may I ask them to make their way to the microphone? And we have one person. Great. Please introduce yourself briefly. And yes, over to you.
Thank you for this great panel discussion. I'm Shinhye. I work for MSF, also known as Doctors Without Borders. I would like to comment and maybe compliment a bit on what Madame Swaminathan was speaking about during her speech, especially speaking about the mRNA tech transfer hub. I think a lot of these efforts are currently actually being complemented with some other efforts from relatively non-traditional actors in the right direction. For instance, I am also following very closely the work of WHO Bio Training Hub, which is to complement the mRNA tech transfer hub by actually providing training to low and middle income country manufacturers and regulators to be able to go in that right direction, to have the actual manufacturing capacity, the technical capacity to receive those technologies. So I think it's important to connect the dots between these different initiatives that are currently ongoing in different parts of the regions, especially in regions that have been less visible than in the past. For instance, South Africa, that is hosting the mRNA tech transfer hub, has been traditionally a very forward-leaning and very vocal country in leading in the global health platform. But for instance, South Korea is right now hosting the WHO Bio Training Hub, but being a relatively less visible, less vocal, I would say, country traditionally on global health. I think these efforts are being a bit less known to the global actors. And also I see some other positive movements in the right direction. For instance, recently, both Japan and Korea had their first ever tech transfer, or are in the process of actually signing their first tech transfer to the NPP. And actually, the company's coming up with more forward-leaning conditions than what NPP originally had in mind. So we are seeing some of these industry champions that are for profit, but that are looking at opportunities where they can contribute to global health in a profitable manner, but not only profit-driven manner. So I think it's time to look a bit outside the traditional industry, the traditional countries, traditional companies, and really tap into these new players that are willing to contribute, but know less about what is out there, know less about how they can contribute and what are the needs. Another area is on the funders. So we have most of the big funders in the PMAC conference, but there are relatively smaller funders that are very public-minded. For instance, there's a new funder right now that is looking at actually funding tech transfer, funding only tech transfer efforts. Or they're also trying to map out different R&D pipelines in the region to see if they can connect a different R&D effort and from the beginning to the end of the production value chain. So my question, sorry, is what do you think is missing from these new players to become more visible on the global health? So what do you think these new players need to do, and what do you think traditional players need to do to be able to bring them more into these discussions?
Thank you so
Apologies
much
for the long comments.
Thank you. So maybe we'll take a few questions and then come back to the panel. And I'd just like to ask our panelists to also keep a note of that. So maybe the lady at the front, and then the two at the back. I think there are 3 more speakers' questions at the back. After that, we'll take the next round and invite others to please go to the mic if you have questions. Over to you, ma'am.
Thank you, and congratulations for the great discussion. I would like to know if the traditional medicine would play a role in promoting this discussion and regulating, in a way, the use of new technologies. For example, we produce evidence towards traditional medicine. Thailand here has great experience, and as so other countries. I come from Brazil, and I just learned how good they are integrating all of this here, as we are trying to do in Brazil. And I think sometimes we really hit on traditional medicine, and we do not look at the commercial determinants of health. So I'm in the middle of this, and I think that maybe we could use technology and evidence towards this promotion of better care with traditional medicine. I would like to hear your thoughts. Thank you very much.
Thank you so much. At the back there, Ms. Aarti. Yeah.
Thanks to all the panelists, and I wanted to ask this question about what can multilateral institutions do to create action points, especially post-COVID, when it comes to interacting on 3 fronts. Firstly, where the key dialogues are happening in terms of knowledge transition, let us say at the corporate levels, can WHO-like organizations engage? The second is to integrate digital health startups, and smaller tech companies who are developing new technologies, as well as for including civil society sector in these dialogues and engaging with them. How can we build that nexus and the network? Thank you.
Thank you. The lady behind. Please, at the back, ma'am. We'll take you. Oh, it's you. Okay, all right.
Yeah, sorry about the crash. Emma Ross from Chatham House. I just wondered what the panel thinks are the prospects for globally agreed guardrails on ultra-processed foods, or really the proliferation of these non-edible, non-food items, and what the link might be with trying to meet climate targets, because some believe some of these targets, like eating less meat, might mean we have to rely on even more ultra-processed foods, and that this is one case where climate and health may not be in alignment. And is technology, new technologies, given this topic, are, as applied to the food system, do you think they are going to make us healthier or sicker? And what should we do about that?
Thank you. And the last person for this round.
And 2 quick questions. One is that in the vaccine area, first to market is clearly very important. And in India, after Serum had early vaccines, there were 2 other manufacturers that had vaccines, but it was great difficulty in doing clinical trials because you already had recommended vaccines, so that you actually had vaccines available for testing or for introduction that couldn't be used. And the second is that, Sumi, I love the sugar legislation for sugar-sweetened beverages. Most of those companies in Mexico, for instance, have zero sugar products, yet there was no replacement. They really fought the legislation without thinking about replacements. And I can never understand why not, because there should be, if there's a tax on the sugar product, there should be a cheaper price on the non-sugar product, and they still have the same market. So Help me understand that, because I don't understand why the companies haven't adapted in that setting. Thank you.
Thank you. We have a range of questions, so if I may, I'll ask different panelists different questions, but please feel free to speak to other one. So Soumya, Dr. Soumya, could you please speak to perhaps the question around linking up different initiatives at the global level, especially with regards to the mRNA, and perhaps also on the issue around multilateral institutions linking up with different actors. Professor Gabriel, perhaps on the traditional medicines piece, and if you could also speak to the question around the manufacturers in India, if you are aware, or if you could comment on another, and perhaps Dr. Precious on the climate and health nexus. Over to you, perhaps, Dr. Soumya.
Okay, yeah, thanks. Very interesting questions. Thank you. So about the new initiatives, I mean, it's really encouraging to note some of the examples, that were given. And I think that in today's world, you need multiple initiatives because the scope of the problem is so huge and the public health needs are so big that one initiative, however good and ambitious that may be, is not going to solve the problem. That's why I said the medicines patent pool has done a good job, whatever they could do in their, but their scope was limited and they don't have the capacity to take on the entire world's problems. So it's great to see the initiatives both from public sector, but particularly the private sector now is coming forward and some of the more non-traditional players are coming forward, forward-leaning, and trying to work with organizations like the WHO, the Medicines Patent Pool. I think that's very encouraging. We need much more of that. There are very few companies who are coming forward, but I was reminded of an incident recently in India where actually a social media activist, just an ordinary person who spoke about the high sugar content of some of the so-called health beverages that are being sold and promoting health. So completely unsubstantiated claims on the cover of that product, saying this is going to build your muscles, and it was actually 70% sugar in that product. But a lot of people buy the product because they think it promotes health. And one activist, with his video that went viral, actually, the company, of course, went after him with a big, with all their lawyers. But what they did do subsequently was reduce the sugar content in that product. The government regulators didn't say anything, but they did it voluntarily. So I think public pressure, public awareness can move some of these companies. Some are incalcitrant, I think, but some will move. And to Roger's point again about, why not think about healthier substitutes for what is very unhealthy, but I think it's a matter of probably they look at the price point and they look at also taste, because some companies have argued with me saying that we can't change because our consumers like this product and our business is to sell our product. And so why are you, even asking us to change? So there are many things that go in there. And then I think about multilateral organizations definitely can play a role. They do play a role in convening, and more the WHO has brought in non-state actors and civil society and others. But again, these organizations like the WHO are themselves very strictly regulated by whom they can and cannot talk to. But I think there's been a much more openness in the recent years in engagement, and we need to continue to do that. Thanks.
Thank you, Dr. Soumya. Professor?
You wanted me to speak about traditional medicines. All right.
From COVID to traditional, yes.
Let me say this. I think that generally, I don't really mind what theoretical basis an intervention may have come from. Suffice to say, they should all ultimately bring an improvement in patient outcomes that is pre-specified and is desirable. Now, if you use that broad lens to view traditional medicines or complementary medicines, and then just perhaps even take a step back and say, why is Western allopathic medicine sort of the standard by which all other forms must be measured? why is Ayurvedic medicine or traditional Chinese medicine, why are these called complementary or alternative medicine? Why is Western allopathic medicine not the alternative to these other forms of medicine? The second viewpoint I would just throw out there for your consideration and just to think about is to say, look, yes, we do have a fairly robust and well-established set of monitoring and evaluation assessments for Western allopathic medicine. But it's not actually that long ago that we hadn't got this set of tools. It was really just since the time of Archie Cochrane. It was really just since that time. And we have since, based on that, developed levels of sophistication and nuance. So when we say, okay, well, the randomized controlled design is the gold standard, but let's say in a vaccine trial in the exigencies of a pandemic, you can't possibly ethically or even practically do a simple randomized design. So then you go and do things like a step wedge design, which the WHO coordinated brilliantly during the Ebola outbreak in West Africa during 2014, 2015. So you've got levels of sophistication up. And to the extent that there is this extension across disciplines, such that now the Nobel Economics Committee awarded a Nobel Prize for a couple, to apply essentially Cochrane's original design to social interventions in development. But they got a Nobel Prize, which supposedly should be original work, for something that happened 60, 70 years ago in a different field. But they applied it differently. Without going into the merits or the demerits of that Nobel decision, this is to say, look, have we reached the end of thinking about the evaluation, design, and metrics of Western allopathic medicine such that we would extend it to all fields possible? Or should we be allowing or considering the possibility that there is yet another set of methodologies out there that would be better suited for some of the so-called alternative and complementary interventions? And that set of tools to judge impact is going to be as valid, but it would require a whole new discipline to study and to justify. Now, that to me is probably a second viewpoint I would like to advance just for your consideration, because I don't know the answer. The third is to say, look, yes, we should definitely take into account the role of tech, because I think that was one of the core components of that question. What is the role of tech, or is there a role of tech in helping us think about alternative interventions? I think that it's already happening. So if you take traditional Chinese medicines, tech has been extremely useful in tracking and tracing, literally from farm to your mouth for herbal medicines. Whereas with traditional pill form stuff, you do have GMP standards, good manufacturing practice, okay, ISO standards, so on and so forth. But if you're looking at herbal therapies, and it's not just traditional Chinese medicine, it's already also in Ayurvedic medicines or other forms of alternative interventions, sometimes it's quite difficult to ensure quality. And so tech has been really good at helping us to make sure that there is no funny business along the supply chain. And in fact, part of Alibaba Health's business, a large part of it, is not about alternative Chinese therapies, but is actually about Western allopathic pills, how you actually track and trace. So I think that is already well shown and well demonstrated. But is there a role of tech in the evaluation? I think on that front, and that's my final comment, we have to be careful. Because tech in that front is a tool waiting for a purpose. And we should never actually think about things that way. We should think what the needs are, what the purposes are, and then to say, hey, is tech a possible instrument to help us get there?
Thank you so much, Professor Gabriel. Dr. Precious, if you could.
Yes. No, thank you very much. That's a difficult question. Well, I would start by saying that the important thing is about the substantiation of claims. I mean, if we say ultra-processed product will be a replacement of meat, we'll first have to establish and determine required daily allowances and determine whether there are any nutritional benefits from those ultra-processed. Firstly, whether there are nutritional benefits, and secondly, whether they cause harm or not. And you can still apply the regulatory framework that I referred to earlier. The second is about the nexus between health and the environment and the regulatory provisions. And I can use the South African experience. We have different agencies that regulate, for instance, the environment, that regulates food, and of course that regulates products. And for the environment, if you want to know whether a product is genetically modified, it will be, for instance, Department of Agriculture that gives it that certificate. But as to whether it's appropriate for consumption, it will be the Department of Health that determines that. One is to determine whether it's genetically modified, and the other. So we have to establish a system where there's integration between different regulatory agencies, so that there's consistency in approach. We don't have approval on one hand and disapproval on the other, meaning you get two different outcomes from two different departments. So alignment in the manner in which we regulate is important. And one particular approach that we've recommended is that when we conduct these socioeconomic impact analysis, it is not normally conducted by one department. It's a joint effort where these, and of course we can also include in the socioeconomic impact analysis, include the environmental impact, so that it's socio-economic and environmental analysis. Normally the environmental analysis, the impact analysis are conducted for other areas, for instance, in the mining sector and so on, but they're not incorporated back into the regulation of food. So in that respect, I would recommend that it be the third leg of assessments before any approval is granted. I just wanted to link back what you said to the traditional medicine, because we can also learn from the traditional medicine experience in that the framework that we use in regulating traditional medicine, it's about product, process, and practice. So if we use the product, process, practice approach, we can also apply it for the food and see whether we can extend that framework to apply in the same way. And as to the technology, I think I tend to agree with you. Thank you.
Thank you so much for doing justice to the question. There are few more questions at the back, so this is maybe going to be the final round, given the time. So yes, please, at the back, please keep your questions and comments brief.
Thank you, Carolyn Reynolds, Pandemic Action Network. This is the best session I've been to, I think, all week, so thank you. A comment and a question. So first, my comment. Civil society, communities, they can't compete with corporate lobbying. efforts in terms of the amount of money and that is put into that. Let's be honest about that, and that has a lot to do with the challenges we face. I would argue, so, and this is particularly for you, Gabrielle, I think as you're thinking about your role with your philanthropies, is philanthropy needs to invest in more advocacy for essential and effective regulatory and harmonization regimes for new technologies to get that balance, right? So that we're pressing for those regimes where to encourage and incentivize new technologies, but also and innovation, but also protect the public. So just wanted to put that out there because there are not a lot of people working in that space. Then a question for Precious. So this session is about the commercial determinants for health and regulations, but of course many of the desired elements that Precious you ticked off, transparency, not relying on self-regulation or self-reporting, self-governing, if you will, the need for third-party regulation, oversight, harmonization, capacity building, public engagement and communications, that also applies to governments, not just to corporations. And so just as companies don't want to be regulated, neither do governments. They don't want those restrictions on their sovereignty. But we know we need that, especially if we're going to deal with something like a global pandemic. So what do you see? I know you are in your your broker role, but what can you say about where you see as that landing space for a meaningful pandemic agreement that's going to result in stronger rules, in regulation and stronger rules for all players that both leads to, stronger rules, but also real accountability that will change government's behavior and make us all safer. Thanks.
Thank you. Any other question? All right. Perhaps we could start with Dr. Precious and then Professor Gabriel. And Dr. Soumya, you could also reflect on the point.
Thank you very much. Anyway, I thought I was going to avoid talking about the pandemic agreement. No, but thanks for the question. It's quite relevant. And it also has to do with, and I'll probably start with implementation, assuming that this pandemic agreement will be concluded in May. If indeed it is agreed to, one would start with domestication. What would it take for countries to domesticate this agreement? And how can we ensure there's implementation? I think that's the first point. Because to have the agreement that is not taken up by countries and implemented would actually be a major loss and a missed opportunity. So in our thinking, as we discuss the agreement, we're also thinking, what will implementation look like? Firstly, because it is state parties that sign up to this agreement, that are signatories to the agreement, our expectation is that there are certain things that are obligations, and the state parties are obligated to do certain things. Now, if it means there must be accountability measures that are put in place where they have to report how well they comply, we should at least integrate those into the treaty and have some monitoring system to ensure that there's compliance. But of course, member states, because of the sovereignty argument, have been saying they cannot be subjected to any sanctions or measures such as punitive measures. And we're saying it doesn't have to be punitive measures. We can look at incentives and disincentives that can somehow encourage them to comply and ensure that they participate in the implementation of the agreement. We are of the view that the most effective measures must be at country level, where civil society participates. There must be structures. I mean, if we say whole of government, whole of society approaches, it must be ensured, if we include it, to say there must be whole of government approaches. We need to understand at implementation level what whole of government approaches mean. It means participation, it means transparency, but also means by which public engagement can be ensured, but also communities can also be part of the process, and they can also be engaged. Because with respect to pandemics, you know, outbreak starts in communities as a cluster, and they end in communities. And if you engage communities from the beginning, it's always important that they are part of the solution, but the manner in which the treaty is being developed at the moment is still at a global level. We don't see that translating to engagements, discussions at country level. And I'm hoping that between now and May, we'll see more of those engagements happening. Even at a regional level, we'll see more of those engagement. Of course, your
Dr.
agency
Precious?
is quite active, and I'm hoping that you'll be part of the process of looking at how implementation will look like once this pandemic agreement is adopted.
Thank you, Dr. Precious. Because we are a little close to the time, so I'll ask Professor Gabriel to also respond and Soumya to give some thoughts before we have a final thought on some actionable takeaway points for the session. So Professor Gabriel and then Dr. Soumya.
I'm very well aware of the long queues at the airport, and I need to get back. So I'll limit this and combine it with my final thoughts. I'll say this. I think that particularly on what happens between now and May, I don't think that we should expect any kind of international treaty or updates to international agreements to be back at the heyday of the globalization 1.0. I think that we should be realistic and pragmatic, as Kishore in his keynote exhorted. We should expect, at best, you're going to have an agreement, and that there is a lowest common denominator set of conditions and clauses, so that you have a common platform, however low that platform may be. But then allow for, even embrace, a diversity of the multipolarity that we find ourselves, such that you would not just hope, but work towards individual countries or blocks of countries or member states in their own best interest and in the best interest of their people to develop their full set. And then at the technical level, between member states, hopefully then find some threads of commonality and proceed that way, rather than drive at something that you know is not going to happen. I can't count the number of times that whatever is going to be signed or not in May has been downgraded. It has been downgraded so many times that it's unrealistic, in fact fanciful, to think that we can go back to even just 20 years ago, IHL 2005, in the aftermath of SARS. So I think that we should actually not just accept, but embrace a multipolar type of perspective and approach, and then work within that reality and work in a new way. And that, I think, is what conferences like PMAC is about, where you don't have to talk politics. You understand politics, and then you talk amongst technocrats about how you work within that framework to make it actually all right.
Thank you, Gabriel. Dr. Soumya.
I think I'll also combine my comments in the interest of time, and thanks for injecting that note of reality and pragmatism. And I think, yes, I think we have to accept and understand the world we live in, and while we can be very idealistic and ambitious, we also have to keep moving forward and taking a step at a time to improve the status quo from where it is now. And that's why I think these initiatives we heard about today are all good and positive and in the right direction. I also think we need to look more at the synergies as well as some trade-offs potentially between the climate goals and the SDGs, and I think this was mentioned by one of the audience as well, and look for win-wins, because countries have made commitments to the SDGs, and countries have made commitments to global climate goals, and I think we can leverage those and see what are the mechanisms through which countries could claim a win on both sides. And there are many examples. Air pollution is one of them, but also looking at the food, ultra-processed foods, and now everybody needs to report on their carbon footprints. I mean, let's use things like that to actually improve health. So I think the health community also needs to start maybe thinking a little bit more out of the box, a little bit interacting with other sectors. And there is now a whole framework being developed at the UN on the synergies between the climate and the SDG goals, but I think not too many countries or groups are thinking about it in that way. But there is an opportunity here to go with the agreed global frameworks that we already have, but then try to bring in and demonstrate through research, data, and evidence how some of these pathways could be taken forward. Certainly requires multi-sectoral action, that's for sure. Thanks.
Thank you so much. Dr. Precious, last words in record short time you might need to make.
Well, of course, the one is, let's have that pandemic agreement agreed to in May. Even as a minimum standard, the goal should be making the world safer and fairer, so that we avoid repeating the mistakes of the past of inequitable access.
Thank you. And on that hopeful note, by our very excellent panel, thank you so much. And thank you to the audience as well for your participation. Please give a round of applause.